All right, come on in. We've got Allison Michels with her parent story for us, her family story. And we'll give it away.
My family is going to try and join. We'll see.
You got it? And I see, Allison, you're joined by somebody.
Yes.
Go ahead and get started.
Okay. Hi, everyone. My name is Allison Michels, and I'm going to give you a little bit of our story. So I'm here today joined by my family. For the first time, all four of us are actually at a conference. My husband and I have been at a few. My daughter and I have been at a few. Mason was at the very first one in 2019. But it's really exciting to have all of us here. I'm here with Ed, my daughter Harper, who's 9, and Mason, who is 7. Mason is our STXer. I actually kind of want to start at the end of the story, or at least where we are right now. Today, we live in Colorado. As of Monday, we moved here. So, I know. And we're a ski family. And if you would have told me that when Mason was diagnosed at 6.5 months old, I would have never believed you. Back then, we were just trying to survive. We were trying to understand what the diagnosis meant. I didn't know what life was really going to look like, but for sure, I didn't think it was going to involve ski boots and mountains, and yet here we are. And it's really hard. It's been really hard, and yet it's been really, really beautiful. So Mason was 6 months old when we got the diagnosis. He had infantile spasms, really low weight gain, and extremely low tone. Check, 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 everything that Ingo was talking about earlier. I remember the conversation. I remember the way the doctor's voice changed. I remember the way that time really started to slow down. It was devastating. We grieved a lot. We grieved the life that we thought we were going to have. We were scared of what we couldn't control. Like many of you, we were thrown in a world of specialists, procedures, emergency protocols, and round-the-clock care. And we faced realities we were not prepared for, like seizure management or seizures coming up without warning, feeding tubes that became necessary, layers of complexity that stretched us emotionally, physically, and financially. And in the middle of it all, we loved him deeper than we ever thought possible. We became fluent in a language of medical acronyms, G-tube care, seizure management, and we learned how to advocate for him in hospital rooms and in school hallways. We've discovered that resilience isn't just about surviving, it's about thriving and showing up again and again. So, yes, having a non-speaking child is really hard. There's grief and sadness in not hearing mama or I love you the way that I expected. And then we discovered AAC, augmentative alternative communication, and a whole new world opened up. We started learning Mason's language, and he started showing us his world. Just last week, he was using his eye gaze, and he asked me and my mom, what do you like to do? And before we could even answer, he said lounging. And if you know me or my mom, that is not anything that we do at all. So it was quite hilarious. And then I just have a really short video of him participating in Trick or Treat. So let's see if this goes. Go Mason, yeah. All right. Yes, this journey has been really hard. It's tested our relationships, our marriage, our friendships, and our family, but it's also deepened our bonds. We've learned how to show up for each other in ways that have mattered most. We've grown together in every hard conversation, every worry, and every small moment of joy. Yes, our other child, Harper, sometimes gets less attention, and that's really hard. And she's growing up with empathy and grit and a front row seat to what unconditional love looks like. I cried this morning when I was practicing this too, Whew, right here. She's not just a sibling. She's an advocate, she's a teammate, and she's one of Mason's biggest cheerleaders, if you know Harper at all. And you can see my lovely photos. Okay. Yes, I'm gonna go back one. Yes, this feels isolating. Watching other families reach milestones we're still working towards even after all this time. And yes, it's also true that we're not alone. These are the few other STXers that joined us at a Move to Cure event a couple years ago. And the one in the pink, her and Mason actually were at school together too, so it was a lot of fun. Yes, it's really hard, but there are other families, there are other therapists, there are other advocates who truly get it. You all in this room, people who show up, people who remind us we're not alone and we're in this together. So if you haven't participated in a Move to Cure event, it's an incredible way to get your community connected. And I've got a really great video from a few years ago, and this is just a good example of what Harper is like for cheering for her brother.
Mason! 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 Mason!
So Mason's walking across the finish line with all his cheering.
Mason! Mason!
So cute. And if anybody has any qualms about the next generation, don't. They're fine. It's us that we probably need to worry about. All right, so therapy. Yes, we have spent countless hours in therapy. OT, PT, speech, feeding, in our home, and traveling across country for literally the best possible care. Yes, the progress can feel painfully slow. And we've learned to measure it differently, to celebrate moments, the inch stones, not the milestones. And it's so hard to put into words the smallest gains that make truly the biggest difference. Like, I remember exactly the time where Mason could sit in a shopping cart for the very first time. Yes, I used to count the delays, and now I count the connections, the courage, and the victories that no chart can actually capture. All right, celebration. Holidays and birthdays can be really bittersweet. They're reminders of milestones missed, and they've become some of our most joyful days. Every Halloween, we go all out as a family with costumes, decorations, the whole thing, because even Ed has a wig on that day, because it's Mason's birthday, and he deserves to be celebrated. We've learned that joy isn't about what's typical, it's about what's true for us and our family. This was really one of my favorites when my mom showed up as Captain Hook. I think we were all a little frightened. But it was great. All right, I'm doing good. Ski. Yes, we moved to Colorado for a fresh start. We have so many boxes to unpack, so if anybody's staying next week, feel free to come to our house and help. And in doing so, we've made room for something new. This was actually a picture of spring break when we were on the top of the mountain at Winter Park. We participated in their adaptive ski program, and truly it was incredible. And I wish I would have put a video of Mason skiing in here, but he absolutely loves going as fast as he can through the mountains, through the trees, and the highest peaks. But skiing has really become a metaphor for our life. Learning to balance, falling down, getting back up, and celebrating every single run. As you can see here, we have like a little GoPro so we can watch his face and see him just like laugh. His dad whips him around all the time. I can just follow up really slowly behind. So this is us on the top of Winter Park not too long ago. Yes, the future is uncertain. You've heard it a little bit this morning, and we believe in it anyway. We believe in Mason. We believe in the science. We believe in the future where our kids have more options and more breakthroughs and more joy, because our story isn't over yet. There's a million things that Mason hasn't done. Just you wait. And that's us. He's an avid Hamilton fan, so. All right. Thank you, and I have 56 seconds left, and I will not take any questions, but follow me on Facebook for more.
I love it. I love it. And welcome to Colorado.
Yes.
Thank you, Allison, and Mason, and family.
Oh, that was great, Allison. Thank you very much. Okay, so I'd like to continue with our talks for this morning. I'd like to welcome Sarah Ruggerio from Children's Hospital of Philadelphia. She is a licensed genetic counselor and is very much involved in the STARR study. Really, she's everybody's boss in the STARR study, including Ingo's. But she's going to give you a STARR study update, and I'll turn it over to Sarah.
Thanks, Jim. Oh man, what an introduction. I like that a lot. I'll start off by saying the first thing, when I got the agenda for the conference, I saw that I was going to follow Mason and the Michels family, and that was kind of my first thought, like, oh no, that's going to be hard to follow. It is hard to follow. We'll make it through okay. It's an honor to be here as always. I always love seeing all of your kids, seeing everyone. It's nice to see so many friendly faces in the audience. As Jim said, I'm a genetic counselor at CHOP. I have a role in kind of keeping the STARR study running in many respects, and I work at the CHOP site to take care of kids clinically as well. So I've been in the world of STXBP1 for a long time, and it's an honor to be here. What I'm hoping to do is introduce new families to the STARR study, because we always have new families joining the STXBP1 community. And then for the families that have seen this first part of the presentation before, I want you to see what we've been able to learn in the past couple of years because of the incredible activation of the community and all of you showing up so routinely for this study. It's been really amazing, and let's show you the progress so far, okay? So we'll go through what the STARR study is as a reminder, right? Let's talk about why the STARR study is important. What's the point of doing all of this? Can I participate? Where can I participate if I'm interested? And what have we learned in our first years of the study? That should say years. So first, what is the STARR study? So the STARR study is our first prospective natural history study that's intended to achieve clinical trial readiness. And there's a few buzzwords in that statement. So I want to explain what this means kind of step by step. So prospective means looking forward. So we decided as a community with the STXBP1 Foundation a couple years ago that we were going to design the study of all studies to put numbers on STXBP1 and follow kids over time to see what development, what seizures, and what communication looks like if we follow the same kid year after year, every 6 months, right? We have multidisciplinary experts to evaluate kids. So we have expertise from many different domains of medical expertise, many different medical experts that can all give their opinions and help you take better care of your child as we go forward. So it's based in clinical visits often. We perform tests of development. We take medical histories and we do thorough exams of your child. We ask a lot of questions before, during, and after. And this is all for the goal so that we can better define this condition, so we can give better medical care to your kids in the future, and we can give better counseling to your kids in the future. STXBP1 is a condition that is generally most often diagnosed very early in life. So what's most often, or what happens most frequently, is you all are receiving this diagnosis when kids are between 6 months to a year of life, right? And what we want to be able to do is give you a better trajectory of what to expect in the future and give you more specific information. Because right now, the information that's given to newly diagnosed families is very wide, and there's a lot of I don't knows in that picture. And it's not I don't knows from lack of trying, but we want to fill in some of those I don't knows, right? And then, importantly, we need to prepare for clinical trials. So we have clinical trials that are ongoing. We have a clinical trial that's going to be starting up soon. And we need to be able to prove that these are working. And one of the ways that we can prove a clinical trial is working is by being able to have a great data set of what STXBP1 looks like typically, and then be able to compare it to what STX looks like if someone receives a new drug. So that's a big goal of our study, and that's why we're doing this. When we were designing the STARR study, our first question was, what is most important to families, and what are the domains that we need to capture? So this study has been referenced a couple of times already, but we have a disease concept model of STXBP1, where we interviewed parents systematically, and we defined what is most important to you all. We're defining the disease from the perspective of the people that are affected by it most. And these are kind of the top symptoms listed in order of importance ranked by families, or how many times they were mentioned by families. And so when we were designing this study, we kept this in mind, and we made sure we had a test for every one of these things that were mentioned. So when any participants of the study, when you're asking yourself, why are there so many questionnaires? It's because we wanted something to get at every one of these domains, right? This is a really busy slide, and you don't need to read all of it. The thing I want you to know is, there are a couple of key things to get away from this. First, there's a lot going on behind the scenes of the STARR study. So we get our data by asking you questions through questionnaires, by evaluating your children in clinic, and then we have some exploratory things that we're doing. So at some STARR sites, you might get an EEG, or you might get blood draws or cheek swabs. You might have sensors put on your child, and all of these kind of more exploratory measures, or all of these measures in general, we're trying to put numbers on STXBP1 and find aspects of the disorder that we could target in clinical trials, or we could try to improve in clinical trials. Okay, and now the exciting part. So how far have we come in the past couple of years? So we've come really far. You all have really come out in vast numbers to be evaluated at our sites across the country. So we have 146 individuals that have been evaluated in this study in just 2 years. And yeah, clap. Yes, you should clap for yourselves. And you can see there's lines on this line graph showing how many kids came back for visit 2, visit 3, visit 4. So these returning visits are going to become super important when we're analyzing the data. We want to see what the trajectory is for every child over time. And the only way we can do that is with return visits. You all have done awesome in coming back for these returning visits, and we have some great what's called longitudinal data to show you from those return visits. On the right side of the graph, of the slide rather, is an overview of how many kids we have in each age group. So you can see the really tall bars are for kids between 0 and 5 and 5 and 10. So we have a lot of kids that are in that younger age group. And then we have less kids who are 10 and up, it doesn't mean that those kids aren't out there. We know kids are out there who have STXBP1 and are in those age groups. It might just be more challenging to travel with kids that are older. There might be other factors we need to look into, but we have, but yes, so I'll skip this slide just to keep on time. So just to highlight, we really want to, if you have kind of a teenager or an older individual who has STXBP1, we'd really especially love to see you. And we really want to have a little bit more data to kind of to fill out that picture of older kids with STXBP1, right? So just a little call to action there. And as a reminder, so why is this data important? So every time, even with 146 people evaluated in the STARR study, we are constantly learning something with every single one of these clinical visits, truly. So I can say for our site at CHOP, we will kind of review the progress of every kid that came into our study. We'll review the results of every child that came into our study kind of in the week following your study visit. And in those meetings, we're constantly making new observations about how this condition can present. And so truly, we are learning something new with every study visit. And so it's important that we keep this going. And I already see how we're able to offer you better counseling and information based on all of these study visits in the STARR study. So we're able to offer you more specific information already, and I think that trend's only going to continue. We hope, and we're getting ready for clinical trial, like I said before. So if we're interested in participating, where could we participate? So we have sites across the United States. So we have one at Weill Cornell Medicine, Children's Hospital of Philadelphia, Texas Children's Hospital or Baylor College of Medicine, Children's Hospital of Colorado, of course, and then Stanford. And there's information on the website, on the STXBP1 Disorders website, on how to get in contact with sites. So some of the first data I want to show you comes from all of the surveys that you fill out before coming into the STARR study. So and what we're trying to capture through all of these surveys, we see your child just for a maximum of maybe 8 hours, one day of a clinical visit, right? And we know that that is not reflective of what every single day looks like for your child. And that's why these surveys are so important. It helps give insight into things that we cannot study in clinic. We can't make your child sleep overnight so we can study what their sleep looks like in the hospital, right? And so we need you to answer questionnaires about it so we can learn more about what this looks like in STXBP1. And so here's data from 2 different measures we collect in the STARR study. On the left-hand side is the Vineland-3, which is a scale of adaptive behavior. This is a little bit of a busy slide. I'm going to try to orient you to it, okay? So you might see a lot of gray dots on the left-hand side. That is a spectrum of many different genetic conditions besides STXBP1 that have filled out this measure in the past. So you can see where other genetic disorders kind of all cluster together. And then the blue and the red, or the blue and the pink, purple, are STXBP1 answers. So you can kind of see what the pattern looks like for STXBP1 compared to even other genetic conditions. And what we also see here is these come from two different survey collectors, but the data looks pretty similar, even though it came from 2 different studies. And so we're already starting to kind of see this pattern of adaptive behavior in STXBP1 from these surveys. On the right-hand side, there's a few less points on this side, but this is called a QI disability test, or QI disability inventory. And this is looking at quality of life in STXBP1. And so this is this is the first time this data has ever been available for this condition. Just a couple of observations is that quality of life in kids changes from age to age. So it's not something that remains stagnant across the life of a child. It ebbs and flows even between individuals. Importantly, it also is, these scores are kind of comparable to some other genetic conditions, which helps scientists make comparisons and use data from other disorders to inform our work in STXBP1. And then, oh, thanks, Charlene. Then the next part of the study is the clinical evaluations. So this is where you come into the clinic and we do a variety of tests on your children, developmental tests, to see how they're performing when we evaluate them. Not just when you evaluate them, but when we evaluate them, right? And these developmental tests are supposed to be play-based most of the time. So you will see clinicians using different toys and some more fun than others, if we're honest, to try to get the kids engaged and see how they're responding developmentally to these when they're asked to do these tasks. And again, this is a pretty busy slide, and you don't need to understand everything, but there's a couple of key things I want to point out here. So the Bailey 4 is our big developmental test that's play-based with all the different toys. And what we're showing here is what Bailey scores look like across the age range of STXBP1, and these are in raw scores, so it's hard to know exactly what it means unless you're really familiar with the assessment. But there's a couple things I want to point out. You can see that if we look at just one age, if we pick an age, let's say pick age 5 on one of these graphs, kids have a huge range of scores that they can have even if they're at age 5. It's ranging from more towards a score of 5 all the way up to a score of 100 at the very top. And so this is a huge range, a huge developmental range that we see in our kids, and it's something that you all know and see as parents already. Parents are always asking us when we come into clinic, why is there such a huge range of development in kids with STX? And this huge range of development that we knew about and saw is now there on this graph, right? And this is really important that we put the first numbers on this and can show it can show it for the first time. We also can see how kids progress over time. So if people have been evaluated multiple times, they're connected by a little gray line, and you can see the different patterns that people with STXBP1 can show us over time and how it's different in every child. Then let's zoom in on our gross motor scores, our tests of gross motor function. So you can see kind of the same pattern, where if we look at all 5-year-olds, there is a huge range of motor outcome. That's all the way from 15 on the scale to about 75 on the scale. Not just me, and so every child has a different pattern. But what you can see, again, individuals who are tested multiple times are connected by a gray line. You can see that the pattern of their development or the rate of their development is a little bit more consistent when we're looking at gross motor. And then this is maybe the most common question I get in clinic. Is the difference that we see in the presentation of kids with STXBP1, is it because of my child's variant type? Is it because of the specific spelling change or difference that my child has in the gene? And right now, though we still have a lot of work to do on this, we're not seeing this pattern. We're not seeing results of developmental testing be influenced by variant type. This is still a big question, and I think you'll hear a lot more from us on this in the next years or so. But this is something that we're not seeing influence the results right now. And I want to point out, I want to finish my presentation with just one other really interesting thing we've learned from the STARR study so far. So when kids come in, some kids are coming into, and this is data just from the CHOP site, some kids are coming into our clinic already with a diagnosis of autism spectrum disorder. And atypical autism or autism spectrum disorder is a common feature in this condition. And what we were really interested in when we started the study is, what would it, if we were evaluating every child for autism in clinic, would we see the numbers change and how many people truly had a diagnosis of autism? And what we did see is when we evaluated every child for autism with STXBP1, we increased that diagnosis number by about 20% or so. And this is even older children who have had the condition and diagnosis for a long time. So this is something that again, is already influencing how we take care of your kids and some of the recommendations that we make. And so in conclusion, a couple of final points. We are still learning with every new participant, so we would love to see you, love to see your child, love to have you if you're interested in coming to the study. We all offer kind of expert care for your children, so we are trying to learn from your children, but also give something back to you, give you kind of a better, give you tools that you can leave with to take better care of your child. We really are learning what is typical for STXBP1 and learning more about what we could target for clinical trials, which is very important. And we're learning what kind of a meaningful difference is in STXBP1, meaning what do families think is a meaningful difference? This is something we're learning through the study as well. So with that, thank you so much to everyone who has participated, families considering participating, and families who have participated and will keep coming back. Thank you so much. Thank you. Yeah. I get a question. Does anyone have any questions? Okay, that's okay. Thank you.
Excellent. Thank you, Sarah. So we're going to continue STARR study discussion. So Andrea Meile from Children's Hospital of Colorado, right here. She's a neuropsychologist, and she actually leads the STARR study here at the Children's Hospital. And she's going to talk more about kind of what Sarah briefly discussed, which is the developmental time course of what's going on in STXBP1 kids. So, Andrea, welcome.
Great. Well, I'm so thrilled to be here. It's so great to see so many familiar faces and new faces out in the crowd. Thanks for traveling. We hope you're learning a lot today. As Jim said, some of my talk, thank you, Sarah, for launching me so well. Some of my talk is, you're going to hear kind of some of the same things, but hopefully that might get, kind of some questions going, thinking about your kiddos and what the assessments kind of mean for them. So just a disclosure slide. Thank you again to the foundation for generously supporting our grant. And then I have some other funding that's not relevant to what I'm presenting today. And so starting off with kind of a thank you slide to all the families who participated, our group in Colorado, our coordinators, who we would not be here without. And this is an outdated photo, so I know our group is already looking forward to taking a new one this year. All right, so just to kind of reiterate, I think you've heard it probably a million times already. So again, what are we trying to do with this study? It's a natural history study, so we're trying to understand what does STXBP1 look like over time, and as many different kind of individuals, as many different kind of ages, races, ethnicities, as we can. The study started with what's called a cross-sectional design, and so we kind of had a vertical snapshot of just kind of one visit, what are all the ages, what do things look like, but now we're going horizontally in kind of this longitudinal design. So as Sarah mentioned, like seeing kids for repeat visits, which has been really exciting. So Sarah mentioned some of the RareX measures, including, so on RareX is the CBCL, this aberrant behavior checklist, QI disability that Sarah presented, and then the CCSA. And then in Colorado and on RareX, the Vineland-3, which Sarah talked about. And then we have these performance-based assessments. Sarah spoke about the GMFM, the Peabody, and then we have the CARS, which looks at symptoms of autism, and then the Bailey, which is kind of one of my jams. We have this kind of picture, if it kind of looks familiar. Sarah had this slide up on her presentation as well. And it's just to kind of point out the variety of objects that are in this kit. We hope that they will be interesting and exciting to your children. I think one of the things I hear the most is, do you have anything that lights up? And no, unfortunately, we don't have anything that lights up. I wish we did. Some of the toys do make sounds, which can be kind of fun for kids. But there is a lot of variety, and one of the things that I also want you to notice is there's a lot of color, and we think that this is particularly important in STXBP1 because of the high rate of diagnosis of cortical visual impairment that we see. And so I like that this measure has things that are red and yellow. I had a family recently tell me their kiddo's favorite color was blue. And so, we're kind of checking the boxes that these should be things that we're trying to remove barriers to your child participating in the assessment, and at least we've got colorful things that sometimes make fun sounds. All right, so the first thing I want to talk about is kind of how is the Bailey doing now that we are 2 years in, and expanding on some work presented previously by CHOP, just that now that we have kind of double the amount of time that we've done. And by the way, yes, we do feel like the Bailey is working, and so we're happy about that. So what I have in kind of combined data from our site and CHOP is 93 Baileys. So this is already extremely exciting for me as a neuropsychologist. I work in this rare disease, and I do work in other rare diseases, and I'm kind of lucky if I get 10 kids sometimes, 10 Baileys. But now, wow, we have 93. And so average age range of 7. And then what we did next was look at what are called floor effects. So the Bailey has the different kind of scoring systems, but in order to we looked at the percent of the very first items, the first 3 items where nobody got any points on those kind of first 3 items. And that was nobody. So nobody had no points on the first 3 items. So we already know that kids were able to access those items. So we don't have kind of what's called a floor effect, where kids, we needed to kind of have different items to have kids show what they could do. So this is kind of one of the really important things that we want to show, because we know that we can track change. We then kind of took, so that's kind of the most stringent criteria, would be 3 scores of 0 on the very first 3 items. Then we kind of took a little less stringent criteria and just looked for an imperfect set of scores on those very first 3 items. And we still found pretty low rates of that, ranged from 6% to kind of 24%. On the Bailey Expressive Language Index was the one that maybe had kind of the most variability. Now I think we're going to try to unpack that to understand why on that measure are we seeing those, and that's going to take some item analysis, and my personal opinion is that some of those items are either not appropriate for kids because they're too old, or we're kind of experiencing some effects from perhaps the diagnosis of autism that are affecting those scores, because some things, another thing that families tell me a lot is that participation in an item depends a lot on motivation, kind of in that moment. Do we want to do this? Do we not want to do this? And so I think that can kind of affect some of the scores in that domain. So the next thing we looked at, so we know that the Bailey is useful for kids with STXBP1, but then we wanted to look at kind of the top of the items. So the last 3 items, or the last 5 items, actually, in each of the indexes, to see if a lot of the population was actually able to do those items, and then we would need to do another measure after the Bailey to better understand your child's development. And so again, what we found is that the Bailey is working very well, The complete ceiling effect, so 5 scores of 2, so full credit on the last 5 items, was 0 to 1%. So we know that the Bailey is capturing the skills of your child kind of on its own. And then again, if we kind of relax the criteria and we just had kind of imperfect scores on those last 5 items, we had 0 to 8%. So, so there were some children who were able to get full credit on some of those final items, but not all of them. So what we feel that we can say pretty confidently, I think at this point in the study, is that the Bailey is working and it's telling us what we want to know, and we're not going to really need to look for other measures to fill in kind of early skills or more advanced skills, if that makes sense. So we're really happy to see that at this point. And so taking the Bailey, what I want to talk about next is just kind of some averages of where scores are. So this is one of the things that I go over in my clinical evaluations, is kind of the age equivalents that we get. So on the Bailey cognitive domain, the average age equivalent kind of across the study was around 11 months of an age equivalent kind of. So no matter what age the child was, the average ability was kind of approaching 1 year old. The minimum level that was demonstrated was around a 2-month-old age equivalent. And then what's interesting is the maximum, so the Bailey goes up to an age equivalent of 42 months. And so some children were actually able to show an age equivalent of 40 months. So pretty close to the top of that scale. So we have quite a range. And we see that range represented in the lower table, where we have the standard scores. So we only get standard scores if your child is in range, in the age range for the Bailey. And so we have standard scores ranging from 55 to 90. That standard score of 90 is in the average range. So there are some children out there who are performing consistently to same age peers. I'm not sure what age they were when they were meeting that, but we know that that is out there. Now I have the language domain. So there's 2 measures on the Bailey that talk about language, receptive language and expressive language. And these age equivalents are pretty close to the cognitive. Receptive is only different, a very small difference. Expressive language is a little harder in our population, which I think families would agree. But then we have a very wide range of some children just beginning to show us communication, and other kids almost going to kind of the max age equivalent, so showing us quite a bit of language. And so, again, I think it's really nice that we have that range like that. Similar standard scores for the kids who were in age, 45 up to 96. 96, again, is average. So we do know, so I just bring up the standard scores, even though that's a small proportion of our population that we would have standard scores to discuss. I think it's important because we want to not assume that we know how a child is going to perform. We want to actually have them show us, because we can be happily surprised. So the motor domain, again, very consistent, around a year kind of age equivalent. The minimum scores are a little bit higher for motor, and I think families also kind of tell us that their kids are achieving motor milestones perhaps a little bit sooner than some language milestones. And again, we have some kids who get right up to the top of kind of what the Bailey is measuring. Standard scores are, again, very consistent. So those are kind of the average scores that we have so far for the Bailey. Now, again, thank you, Sarah, for emphasizing the importance of these multiple visits. So the data that I have to present today on multiple visits is from 42 participants, which is really just stellar. So this could be just more than 1 visit. So some families have done more than 2 visits. But again, really kudos out to everyone who's traveling and making this time commitment, because this is just thrilling. So now that we have multiple visits, when I see a family for the first time, I am able to compare your child to their peers in terms of norm scores, if I have them, or age equivalents, and that's kind of as far as we can go. But when I see a child for multiple visits, then I can start to talk about your child's individual trajectory. And I can do that by looking at change in raw scores, and several other different types of scores. So up here on this table, I just have some raw scores from 2 kids on the Bailey. And so we have kind of time 1 has the 1 next to it, and then time 2. So we see for cognitive, for example, the raw score went from 83 up to 90. Then a next child had 2 raw scores that stayed relatively the same, 54 to 56. And then the last child's cognitive skills, so I have 3 kids up here. We have what seems like a bigger jump, score from 48 up to 69. And so I have all these raw scores across time. And our group is planning on doing significant analysis on our raw scores to try to really understand what their differences are telling us in terms of movement. One of the other things, though, that I find a little bit hard to interpret for raw scores is what do they mean in the moment? Because I don't know what 83 up to 90 kind of means. Like, is that common growth over time? Is that a big jump? Do we actually expect more growth? I don't know. I'm happy about it. It seems good. But from a research perspective, we really, need to do better than that. And so, and especially if we are looking for change in a clinical trial where hopefully we're looking for gains, but you know what? We also need to be able to capture declines if they're there. So we need to really have a pretty rigorous approach to understanding the movements in these scores. So this is a paper not related to STXBP1, but it's related to measuring change in a neurodegenerative disorder that we see in children. And I think that we can take some important lessons from it for our group. So there's this kind of table that talks about the different types of scores, and I've mentioned some of them. Standard scores, we get those only if we have norms, so only if your child is within the range that the measure was created. We have raw scores, we have age equivalents. Age equivalents are certainly, the most kind of, I think, easily translatable to families. It's helpful for me to say, okay, 12-month age equivalent. I kind of feel like I know what that means. I know what that means more than like an 83 on the Bailey cognitive, even though I give that measure a lot. And so then we have these things called GSV scores. And so it stands for growth scale values. And I would say that this is probably one of my favorite parts of when I'm seeing a child or an individual kind of for multiple visits is to kind of look at these GSV scores. And so while our group is going to continue to look at all the different types of scores, raw scores, age equivalents, and try to understand movement, I think one of the other things that I'm excited to do is try to see if these GSV scores can also help us understand change. And so this is a picture of a table that I can get if I run an additional analysis using the Vineland. So you can see we have test 1 scores, test 2 scores. The test 1 is 2022, test 2, 2024. So we have about a 2-year gap. And we have the adaptive behavior composite and then kind of these other scores from the Vineland. And you can see that, wow, there looks like there's been some significant decreases. All the scores are moving way down. And if my initial look at something like this would be, wow, what do we have here? What's happening? But then when we look at the GSV scores for this individual across time, you can see that not only have all of the scores actually increased, there are some that are in a gray box, and that means they've increased in a statistically significant way. So to me, again, this takes one step away from me kind of having to use my gut to say, that seems good, where this is actually already built into the Vineland, and it's, we actually have stats to show us that this movement is really meaningful. So, so the way I think that we can kind of understand the gap is that when I see a loss in a standard score, this just means that the gap between your child and peers has increased. We don't necessarily know until we look further into raw scores or GSV scores if that's because your child has actually lost skills or have they just been slower to gain the skills that we would expect them to gain because time has moved on. And so I feel like the GSV scores also tell me a lot about, or can also kind of help me plan with families for how is it going? You know, there aren't enough hours in the day, and you guys are working so hard to get your kids into therapies and extra activities, and everybody's really busy. And I think sometimes it's useful to say, you know, hey, we have, you know, we're making a lot of gains here. See, our work is doing something, like this is being justified. Or if we don't have gains, maybe we want to focus our time there. Maybe we can pull time back from something else that we're doing. So I think it can help plan, and that's something else that I really like. So just coming back to our example, I have the GSV scores. Ooh, sorry. I have the GSV scores in there. So we have the raw scores, which is like the 80, the 90, 54, 56. The GSV scores are in bold. The GSV score itself doesn't mean anything. So it doesn't matter that it's 510. It could say 710. It could say 1110. The number's meaningless. The point is the movement. And so here I have the statistical significant difference that's in the manual for the change in scores. So we already know kind of what we're looking for. And if you look at the bottom row, I think these scores kind of make sense even if you just look at the raw scores, because we have a big gap, 48 up to 69, 35 up to 42, 66 up to 71. So all the ones that are starred are statistically significant. But then I have the top line, kind of these boxes, because to me, so we have an increase a decrease rather of 5 in receptive language, 42 down to 37. Is that something I need to worry about, or is that just normal variability? And this would tell us this is normal variability. We don't need to worry about it. In contrast, we have 83 going up to 90 for gross motor. That's a statistically significant change. But 83 going up to 90 in cognitive is not a statistically significant change. So again, I just think that it really helps that this is grounded in some statistics, and it really helps me know what we need to focus on when I'm talking to families. So what I'm hoping that we can do is expand, since I'm talking about this on a very individual level, I'm hoping that we can apply this to our entire sample. So that's some of our coming work. So thank you so much for participating in our study. We can't say that enough. We are still hoping to add individuals that are older, increase our racial diversity. We kind of already talked about that. We're happy with the Bailey. We're excited to kind of be using this measure. We appreciate you having patience with us. If some of the tools seem a little bit babyish, we're just hoping that your child still likes to interact with them, and we're just trying to kind of discover what that instrument can tell us about movement over time. So yeah, hopefully we'll continue to see you. Please come for 6-month visits. I'm excited to include other data from other sites who are also here, and look a little bit more into behavior and kind of some stuff around autism. So that's kind of what we're hoping to do next. Thanks.
Thank you, Andrea. Does anybody have any questions? We can take one question for Andrea. Anybody? If not, you can find Andrea. Anybody have any questions for her? Can I just say real quick that we see Andrea, I'll just out ourselves. We see Andrea, love working with her. This has been super helpful for us. We saw our son actually start to dip down, but then he came back up, and it was really cool to see. So it was really cool to see these numbers like in real time for your child. So it is really cool to be part of the study and to be able to get this information. All right. Thank you, Andrea.
Thank you, Andrea. So we're going to continue with another talk from the Children's Hospital of Colorado group. This is Megan Abbott, who's an assistant professor in peds neurology, and she is going to talk about the development of a new type of severity scale that can be used to assess our STXBP1 kids. Megan, thank you.
Well, hi, everyone. I will start how everyone has started, which I'm so thankful to be here. It's just wonderful to get to see all of the STXers and all the families that we get to see in clinic outside the hospital. So it's just wonderful to be here. And I am excited to talk to everyone today about a new clinical severity assessment that we have made to evaluate STXers. So we're going to talk about how we developed this severity assessment. Oh. Yep. Apparently I'm being too quiet. There we go. We developed, I'll talk about how we developed the clinical severity assessment and then go through some data of how it has looked so far in STXBP1. So before we get into the clinical severity assessment, I wanted to talk through why do we need this? Can't we just look at epilepsy? Can't we just look at seizures? We know a lot of our STXers have seizures, and a lot of clinical trials before have used seizures as one of their endpoints. And I think it's important to step back and think about kind of what else is involved in STXBP1. And so for a long time, we've thought about, as a community and as neurologists, what's really driving severity in these conditions? Is it seizures? Is it the gene? Is it both? And I think over time, it's been found that, as we know, it's STXBP1. It's the gene that's really driving all these different changes we see in our kiddos. And that's been shown time and time again in different conditions, including STXBP1 and SCN1A and SCN2A and other conditions that you guys know, which is that developmental delay often precedes seizures. Once seizures are well controlled, delays persist. And so it's not necessarily that seizures are driving severity, but that they're a part of the whole clinical picture. And so it was important to start thinking about, what should we measure? What do families care about? What's important to our patients? And what are we seeing as clinicians? And so we have several examples of this, one of which being CDKL5, where they kind of went through parents' top concerns, clinicians' top concerns. And you can see that seizures are up there as one of the concerns, but they are not the only concern. We know that we care about communication, motor, sleep. All of these are things we want to measure and potentially things that we hope would get better in a clinical trial. And I luckily had so many people come before me to talk about the STXBP1 disease concept model, and I think you can see how important this study was and how far-reaching its efforts were into getting us where we are today. But just wanted to point out a few things, which is that, once again, while seizures are part of the disease concept model, there's many other domains that are very important, including behavior, vision, motor, communication. So I'm starting to sound like I'm on a soapbox, but while epilepsy is the major concern, it's not the only concern, and so we needed to think about an outcome measure that could measure the other things we care about, being speech, motor, sleep, behavior. And so that brings us to the clinical severity assessment that I am going to focus on, which actually was originally designed in CDKL5. There's a team that got together for CDKL5 at our institution, Dr. Demarest and Dr. Banke among a few, who started to design and then validate a clinical outcome measure in CDKL5 called the CDKL5 Clinical Severity Assessment, or CCSA. There's a lot of acronyms in this work, but they were able to validate that in CDKL5 and show that it works really well and is able to cover multiple domains that I was talking about. And so I wanted to show an example of some items and then talk about how we've modified it for STXBP1. And so the scale in general is on a 0 to 100-point scale, with 0 being the least amount of impairment and 100 being the most amount of impairment. And so these are just some examples of motor items which involve, how does your child stand? How does your child walk? Is that with maximal assistance? Is that with 2 hands or 1 hand? And so we can grade that over this scale from 0 to 100. Same thing is true for communication. So when we're evaluating your child in the clinic, we are looking to see, do they make purposeful vocalizations? Are they non-purposeful? And we actually can use their age as well to help us know what to grade. And as well as knowing, how many words do they have? Are they word approximations? Are they using an AAC device? All those things are built into the scale. And the other domain that the severity assessment covers that we do in the clinic is vision. And so these are a couple of our vision items. If you've been to clinic with us, you know that CVI is something we like to talk about and diagnose, and the vision items help us give that diagnosis as well. And so some of these items are fixing and following, our optokinetic nystagmus reflex, which if you've been to clinic is that iPad with the lines that swirl through your child's face. And we are able to see if your child can track and how their eyes are responding to that test. And so we were able to take this assessment, the CDKL5 Clinical Severity Assessment, and the Colorado team and the CHOP team got together in a few sessions and talked through the items and talked through what items would be missing for STXBP1 and what items would be good to add. And we were able to add some trimmer items as well as some vision items to try to just get more at the kind of nuances that STXBP1 has that are different from CDKL5. And then we started piloting the STXBP1 Clinical Severity Assessment, or SCSA, through the STARR study. And I'm really excited. We have 123 patients that we have the SCSA scores in, and I get to share really exciting results, which is that the score has worked really well. And what does that mean? What does it mean that a score works well? Well, we can see that there's really nice distributions through most of these domains, including the overall score has a nice bell curve, which means that everyone was not all the way at the bottom and everyone was not all the way at the top, what we call floor and ceiling effects, as well as that we were able to demonstrate the score can capture a wide range of severity, even within STXBP1. You'll see that the vision score has some scores kind of clustered near the bottom or the less severe range of the score. And I think we have an explanation for that, which is that around 50% of STXers have a diagnosis of CVI, or cortical visual impairment. And if you have a diagnosis of CVI, you tend to score higher on our vision domain score. However, the other half of STXers do not have a diagnosis of CVI and therefore score lower on the score. So about half the scores cluster in the lower end of the range and half are on the higher end of the range, so more of a bimodal distribution. This is once again just showing the scores in the 3 different domains. So we have motor, communication, and vision for our clinician-administered SCSA. And in terms of severity, we see that the communication scores tend to be on the higher end of the range, showing that maybe we have more impairment in the communication domain, followed by motor, followed by vision. And after we look at the distribution of scores, and we look at kind of how did these scores compare across STXers, we also want to make sure we're looking at, are the scores skewed? Do they have kind of good means and standard deviation? And these are ways we tell if the score did well or performed well in STX in the same way that it did in CDKL5. And we were able to see that, once again, the scores had a wide range of scores, that there wasn't skew other than in the vision score, which I think can be explained with the CVI that I talked about. And the other piece of validating a score is something called factor analysis, which I'm going to break down, is essentially, do the items that are in the scale still fit into the buckets we thought they fit into? So I talked about motor, vision, and communication. Those are our buckets or factors, and we looked to see if the items that we have in the scale still fit within those buckets for STXBP1 and still make sense for the condition. Similar to, like, these are variables, education, family situation, and income, that all fit within a factor, socioeconomic status. So this is what we're looking at with the scale. And these are a lot of numbers that you guys do not have to look at, but we have set cutoffs for if these different variables or items within the scale are fitting within these buckets or domains appropriately and with good metrics, and that the scale still had the same number of factors or domains as it did in CDKL5. And I'm excited to say that all of the items listed did fit within those factors or domains, and that the domains still worked well in CDKL5. And so the takeaway from this is that this was a measure that did a really good job in STXBP1 demonstrating a wide range of severity and capturing what your kids can do in motor communication and vision. There wasn't significant floor or ceiling effects other than what I talked about with vision, with CVI or no CVI. And the way that the factors or domains were structured in CDKL5 continued to work in STXBP1. All of this leads to an exciting thing, which is that we could use the SCSA in clinical trials and that it is going to be used in the upcoming CAPSIDA trial. So we're very excited about that. Whoop. And I just wanted to end with a thank you. Thanks for letting us see your kids. Thanks for letting us get to do this work. And we're excited to continue. This is a pic of my family. I think the last time I was here, I was very pregnant with twins. So they're here now. They're 10 months old. And just really thankful to get to share in your families and share mine. Thank you, guys.
We have time for one question. And you can also get Megan during the breaks. Okay, thank you so much.
All right, for our final speaker of the morning, I want to welcome Jillian McKee from Children's Hospital of Philadelphia. Jillian is a neurogeneticist and epileptologist, fellow in Peds Neuro, and she's going to give us kind of a primer on understanding EEGs. So, Jillian, thank you.
All right, thanks, Jim, for that introduction. My talk's going to be a little bit different than the ones we've just heard in the last section. Really just wanted this to be an overview for families about EEGs, why we get them, what they can tell us, and then give you a little bit of an understanding of some of the basic science behind them. But the reason I wanted to talk about this today is we've been getting lots of questions about families, about EEGs, how to understand reports, when we should get them. And then since incorporating research quantitative EEGs into the STARR study, had a lot of questions about the differences, what the difference between a clinical EEG and a research EEG is. So I just wanted to give you guys a basic overview of that. And then feel free to grab me with any questions throughout the weekend if anything comes up. So brief outline of the talk, gonna do some EEG basics, very, very brief history. What is an EEG? Talk about some types of EEGs. And then very, very briefly, I'm gonna focus on how EEG is helping us understand and treat STXBP1. So EEG is actually very, very old. There's been lots of buzz about it lately, but this is a super, super old test. The origins for EEG go back to the 1800s when scientists first discovered that there's electrical activity going on in the brains of animals. And then really, really took off in 1924 when Hansberger performed the first human EEG. Then EEGs have been in clinical practice around the world since the 40s or 50s. So this is a really, really old technology, but there's a lot of new, exciting ways to analyze this data that have come up in the last few years. So what is an EEG anyways? An EEG, it's a medical procedure, very non-invasive, to help understand the function of the brain. Kind of like an MRI gives you like a big picture overview of the structure of the brain. EEGs can really help get a sense how do parts of the brain communicate with each other. So you have small electrodes that are either glued onto an individual's head, or you can use a cap-based system. It measures the electrical activity, as I mentioned. And then we have both visual and computational techniques to decode distinct activity patterns in the brain. And as I mentioned too, EEGs can be performed for both clinical and research purposes. So this is a very, very basic schematic of an EEG system, one using one of those cap-based electrode nets. So you can see a patient sitting there with this cap of electrodes on his head. Each is connected to a wire that takes the signal to an amplifier. And you need an amplifier because these electrical signals are very, very tiny, so we need to magnify them many, many times to be able to see them. And then the signals are fed into a computer where we can display them on a screen and then perform different computational analyses. So this is kind of a scary picture, and I'm not going to go into all the details of this, but just want to give you a brief overview what actually makes the EEG signals. So as I mentioned, brain cells talk to each other using electricity, and this is transmitted across synapses, which are like the gaps between those brain cells. And when many of these cells talk to each other, they generate electrical signals that can actually be recorded on the scalp, on the surface of the brain. So this is a picture of a normal teenager's EEG. When I'm sitting in clinic reading EEGs, this is what I'm looking at. There's many different ways you can visually display an EEG, but this is one of the more basic ways that we do this. And just to orient you a little bit, blue squiggles are coming from the left side of the brain, red squiggles from the right side of the brain. Each of those little groups of 4, the top lines are electrodes towards the front of the head, and the bottom ones are coming from the back. And when you look at this just to get a overall gestalt, you see that there's some sort of organization there. In each of those groupings of 4, you can see towards the top, it tends to be a little flatter with faster activity, and then towards the back, you see these more higher amplitude undulating waves. So this is what a normal EEG looks like. Contrast that to this. Ingo mentioned that infantile spasms are very common in STXBP1, and this is a snapshot of an EEG from a baby with spasms. You can see this is that pattern that some of you whose children have had spasms may have heard of called hips arrhythmia, where you get these high amplitude disorganized waves. It's kind of messy. If you turn the page upside down, it kind of looks the same. You don't really see any clear organization. And then you can see that period in the middle there where it becomes flat. And that's the EEG signature of an actual infantile spasm. So when looking at these visually, we can see clear differences, and this is how we read EEGs for clinical purposes. But we can also look at these signals a little more detail. When you're talking about EEGs, we tend to break the frequencies down into specific frequency bands, from very slow undulating waves, delta frequencies or theta frequencies, up to very, very fast squiggles in beta and gamma frequencies. And we can measure the amount of the signal that falls into these different frequency bands. So just keep this in mind. I'm going to come back to this in a minute. First, just want to talk about clinical EEGs. So why would your child's doctor want to get an EEG? So EEGs are really helpful for diagnosing seizures and epilepsy, and then also looking at disease-related brain activity, things like slowing, like are those waves slower than we would expect for a child's age? Is there any asymmetry? Is something happening on one side of the brain that's making those waves look different than the other side? They can be useful for classifying the types of seizures. We talked about infantile spasms already. There's other types of generalized seizures as well, and kids can also have focal seizures, meaning they're coming from just one spot in the brain. And EEGs are also incredibly useful when trying to localize where in the brain a seizure is coming from when you're considering certain treatments, such as surgical treatments. And then also, once you've started a seizure medication or some sort of therapy, EEGs can help you see whether that's working. So there's many different types of EEGs, and these differ from institution to institution. But some broad categories are what some people might call like a routine EEG. That tends to be like a spot EEG in clinic, normally about 30 minutes. Often the child's only awake. We're not lucky enough to capture sleep with these EEGs. Sometimes, especially for infantile spasms, we'll do something called a 4-hour EEG, which is exactly what it sounds like. It's a longer EEG. The goal is mainly to try to capture sleep, especially in infants. And then if you need even more data, you can be admitted to the hospital for something called long-term monitoring or continuous video EEG, where you can stay a few days with the EEG in place. There's normally a video in the room, so you can correlate things you're seeing the child do with changes in the EEG. You can do a version of that at home, too, called an ambulatory EEG. And then for pre-surgical workups, people considering epilepsy surgery, there's more advanced forms of EEG, such as stereo EEG, where you actually implant depth electrodes into the brain. And then an older technique called grids and strips, where you'd put the electrodes that you put on the scalp for a normal EEG, but under the skull on the surface of the brain. So what to expect? Many of your children have already had EEGs, but for those who haven't, it's a non-invasive test. You do sometimes need to sit still at least for a little bit to get a good sense of the brain activity, because movement can shake those wires and move those electrodes and make it harder to read. There's no pain or discomfort. Sometimes, especially if you have the EEG electrodes on for a longer period of time, you can get some irritation where the electrodes are. And then sometimes people will perform what we call activating procedures, such as photic stimulation, where they flash those bright lights, or have your child do hyperventilation, like blowing on a pinwheel or pretending to blow out the birthday candles. Those are nice tests to do too, because they can bring out some abnormalities in the brain and help make them easier to see. So we get lots of questions about what does your EEG report mean. And this is just one example, actually, of a normal EEG. And this is also varies from center to center what these look like. But they all should have certain key components. They should describe the background frequencies, so those the fastness or slowness of the different squiggles in the background. If it captures sleep, we'll describe sleep. Talk about any seizures, obviously, and then any other focal abnormalities such as slowing or epileptiform discharges, which are like spikes or sharps, those little signs that your brain is prone to make seizures. All right, and now switching gears to talk more about the differences between clinical EEGs and research EEGs. So as I mentioned already, for clinical EEGs, the main goal is diagnosing and treating patients. We use these in hospitals and clinics to really provide the best clinical care for your children. Research EEGs, on the other hand, have a different goal. We want to analyze the brain activity for research purposes. They're often more detailed and include complex computational analyses. These can help us identify biomarkers of disease, which I'll talk about a little bit in a bit. And then they can also identify subtle patterns that you might not be able to see just with your naked eye when you're looking at a page of EEG. There's also some differences in the way we acquire clinical and research EEGs. They tend to have different sampling frequencies, so that's how many times per second you're looking at that signal and measuring it. For clinical EEGs, that can be a little lower resolution. But for research EEGs, we really want very high quality data, so we sample it at a much faster frequency. We also sample the surface of the head at a higher density for research EEGs. So for our research EEGs, we use these caps that have 128 electrodes, versus clinical EEGs only have 19 typically. And these are a lot of words, but for the sake of time, I'm just going to go, pictures are sometimes much easier. So this is just an example of two subjects getting both a clinical EEG and a research EEG. And for full disclosure, these are my children. On the left here is my son, Wolf. When he was a baby, he's 4 now. But he had some very, very scary breath-holding spells, so had a clinical EEG. But you can see those electrodes are glued and taped on and then wrapped up by an EEG tech. And this is just done in an outpatient clinic. And this EEG lasted about 30 minutes. And then on the right there, you can see my daughter, Willa. She's 7, and she's a very proud participant as a control EEG in the STARR study. So just to put a plug in, if there's any siblings out there who want to help, we would love to, when you tag along for your visit, and we can gather some EEG data on you too. It's helpful to be able to compare between STXers and then healthy controls. But you see she's wearing this elastic net-based cap system. It's much easier to apply. You don't have to glue it on. Just have one of our research coordinators put it over your head. It's pretty well tolerated. And you can see there's many more electrodes. You get better coverage with that system. All right, and then very briefly, because I know I'm standing between you guys and lunch, I'm going to talk a little bit about EEG biomarkers. So what is a biomarker? And there's many different types, but broadly, they're measurable signs, so that's important, they have to be measurable, that tell you something about health and disease. There's EEG biomarkers, there's blood biomarkers, there can be CSF biomarkers, there can be biophysical biomarkers. But when we're talking about EEG biomarkers, we have several goals for what we want to be able to determine from them. So biomarkers can be diagnostic, so it can be a unique EEG signature of STX that shows something different than we would see in a neurotypical control. So that's why having those controls is important. They can also be prognostic or predictive, so they could track with the severity of a disorder and can help stratify patients into different groups. And they can also be responsive, meaning that they change with treatment. And that's ideal for an outcome measure for a clinical trial. Ideally, we want it to be all three. We want to have a biomarker that's unique and different in STX. It corresponds with severity, and it changes with treatment. So we have developed a QEEG, or quantitative EEG pipeline, to analyze these research EEGs to try to look for biomarkers. So what you can see here is a noisy snippet of an EEG. And what we do is this pipeline cleans the data up and selects good, clean segments for further, more detailed analysis. And it's actually kind of remarkable. You don't need very much clean EEG to do this. We only actually need a few seconds. So if you're worried your kid moves around a lot, it's actually not a problem. As long as we can get them sitting very still for a few seconds, we can get some good data. And then we go and we look at the different power in those different frequency bands. So you remember I showed you this before. And we can do this globally across the whole brain, or we can look at specific regions, so either in the front or the back. And then in addition to looking at just like the power of delta activity, we can look at ratios. So how much delta is there compared to alpha? But if you can think about that, we have all these different frequency bands, every possible combination of ratio, and every possible area of the brain. That's a lot of EEG features. So how do we know which ones to look at? So what we did first was developed a machine learning model that would classify EEGs based on whether they came from kids with STX or healthy controls. And then we used that model to pull out which features were most important. And you can see here on the right, this feature importance plot shows you which of those features the model used to say, this EEG comes from a kid with STX, or this EEG comes from a kid without STX. And the most useful feature was this alpha-theta ratio in the front of the brain. So then we can pull that out and look at that in more detail. So here what I'm showing you is that frontal alpha-theta ratio in 3 different age groups, in control individuals in green, in STXBP1 individuals that had clinical EEGs in that light purple color, and then in the darker purple is our research quantitative EEGs. And what you can see is that pretty much across the lifespan, that alpha-theta ratio is lower in individuals with STX than in neurotypical controls. So that's really exciting that this could potentially be a biomarker of STX. And what we're looking at now is to see how well that actually correlates with the various outcome measures that Sarah showed you and Andrea showed you. I'm not going to go into all of that detail now, but we're making some exciting progress. So yes, I finished in time. Will not be the one to delay you for lunch. So I hope I was able to share a little bit about EEGs today and why we get them, how to interpret them, how they're useful. But feel free to flag me if you have any questions. I'm happy to answer them. Thanks.
We have time for one question. Jared.
I have one from online here. John would like to know, Has there been any movement on the approval of the cap-based EEG versus glue? Is the cap-based EEG FDA approved? Is that a...
So the ones we use are, yeah. There's many different very exciting EEG technologies under development, which may be something that we could use in the future, like home-based ones. There's ones with like only a few channels that like kind of like a headband that you could wear at home to monitor seizures. Many people are looking into this and exploring it for potential outcome measures for clinical trials. It's all exploratory now, but expect lots of exciting changes in the next few years.
Thank you.
All right, I know I am standing in between lunch and y'all, but I wanted to just close today's session, or this morning's session, by saying I know that was a lot of material, and there was a lot of technical information, especially in the last few talks about, ranges and floor effects and ceiling effects, and we wanted you to understand some of the approaches and the data and the science behind the way that we're looking at these measures as they apply to the STXBP1 population. As we mentioned in the beginning of the day, we are running. We are trailblazing and we are running because of the fact that we've only been at this for 16 years. It means that this is the first natural history study we've done. We've only been doing that for the last 2 years. We're starting the first gene therapy clinical trial this month. And so all of these things, we have a lot to do to make sure that as best as we can, the measures that we're using are appropriate for our population, and we understand the data that comes out, out of the trials based on that. So I know it's a lot of information. These talks will also be recorded, and please, the speakers are here, so find them and ask them questions. All right, we are gonna break for lunch. We will come back at 1:20. There is also a music therapist that is going to be in the Stanley Ballroom. So if you were going back down the hall and you went down where the research arm is, go to the end of that hall and the music therapist will be there. Okay, thank you all.